Welcome to the Academy's Lunchtime Webinar Series. Today's webinar is titled Patient Communication Strategies for Improved O&P Outcomes and is presented by Beth Garland, PhD, and Robert McLaughlin, PhD. Both speakers today are clinical psychologists and faculty at Baylor College of Medicine. They co-teach, along with Joshua Ute, a course that the OP students take. The course is Health Behavioral Counseling, in which they teach the skills that we are going to talk about today. Dr. McLaughlin is the Dean of School of Allied Health Sciences at Baylor College of Medicine, which has the MS program in orthotics and prosthetics. Dr. Garland is an assistant professor at Baylor College of Medicine and a clinical psychologist at Texas Children's Hospital, where she works in support of clinical adolescent medicine. We will now take a moment to turn the time over to Dr. Garland and Dr. McLaughlin.
This is Bob McLaughlin. Thank you very much for having Beth and me here today. We're thrilled to be able to introduce to practicing OP clinicians some of the skills that we're training our graduate students in our Master of Science program here at Baylor College of Medicine. We ask you to stay as present as possible. If you find your mind wandering during the presentation, please try to bring yourself back into the room. We're all learners. There are no mistakes in this process, and it's easy to get disengaged with one's own thoughts. But we have a lot we'll try to get through here, and we beg your indulgence as we do so. We need to start by saying that we have no relevant disclosures to make. Beth does have a couple of grants that are listed here, but we have no conflicts or in financial relationships to disclose with regard to our presentation. We also need to give our profound acknowledgements to professionals and students within the OP field who have helped to raise our awareness of the suitability and applicability of the skills we teach to your practice. Our particular thanks to Ashley Mullen, who is a faculty member and assistant program director for our OP educational program, and to Tyler DeLeo, who is one of our students and who helped us to orchestrate this webinar here today as part of his master's research project for attainment of his degree. We also need to give very sincere thanks to Josh Ute, also a co-instructor with us and another assistant director of the OP program. And it's through his efforts that we have gained what knowledge we do have about the practice within your field. What we have learned through our conversations with these professionals is that there has been a major transformation in prosthetics and orthotic practice in recent years, with a move from mere technical skills in customizing and fitting devices to being a professional member of the healthcare team in close collaboration with other professionals and working with your patients across the lifespan to help increase their functionality. What that also helps us recognize is that it requires different skills from the OP professionals in terms of the ability to provide lifelong comprehensive patient care. And we think the skills that we have to bear can be greatly facilitated with regard to dealing with some of the challenges people may encounter in clinical practice. So we ask you to consider during our comments today what situations you encounter that may be challenges for the communication interaction with regard to your patients' collaboration with you with regard to addressing their functional capacities. Occasionally, we know we do encounter patients who don't seem to follow directions well, who may second-guess instructions, who don't seem focused on their health in order to make an optimal change to increase their functioning and to reach even their own stated health outcomes and goals. Sometimes you may even wonder why your patients keep returning if they're not going to be doing what you ask of them. These are patient-related variables, and they put communication strain on the work that we do, but a lot that we do as clinicians can help by using strategic interactive language to facilitate patients' motivation and adherence to recommendations that can help the likelihood of their obtaining their own preferred health outcomes. Research documents that it's effective to use the skills we're talking about, which we regard globally as health behavioral counseling skills. Whenever your patient is ambivalent, has conflicting feelings about engaging in a behavior persistently, when they seem to get stuck, or when they wish things are different than how they are, and yet still find themselves immobilized to act in ways that will benefit themselves. It's not necessarily to use these skills when the patient really is ready and performing effectively. And also when patients are in acute danger and we really need to step in. But in other instances, as we'll learn, the patient is the primary person with the largest role in their health outcomes, and we are more effective in working with them when we can work on increasing their proficiency in helping themselves. One of our prior students had done a research project in which he surveyed orthotic and prosthetic professionals to find out what were some of the most challenging communication scenarios. And you'll see on your screen now the top candidates that were presented by his respondents in those instances. So you may see here some familiar situations that you encounter as well, and we encourage you to think about these kinds of situations as we work through the skills we'll be talking about today. The objectives for our webinar today are that you would gain the capacity to be able to explain the spirit of motivational interviewing. Motivational interviewing is the particular approach to health behavioral counseling that we teach our students here at Baylor College of Medicine. It has a strong empirical base and in fact competes with cognitive behavioral therapy as one of the most researched and research-supported interventions with regard to behavioral health. We also hope that you'll end up this webinar being able to list and implement 4 fundamental processes of motivational interviewing and have a few techniques in mind to help you assess the severity of ambivalence when your patients experience it, and also their readiness to change, which we'll address in just a second here. We also hope that you'll be able to formulate questions to elicit change talk and mobilization talk from your patients, and we'll see why that's an important mechanism for behavioral change, and that you'll be able to identify a strategy to help you continue learning across your career how to use these kinds of skills even more effectively. I mentioned readiness, and that appears frequently in the literature as a primary predictor of whether someone is going to be able to engage in behaviors that will help them reach their functional outcomes. This article from the Journal of Biomechanics has particular relevance, we think, to your profession and indicates that the single most important predictor of behavioral change is readiness on the patient's part, which is why motivational interviewing takes the focus it does on our patients' personal investment and commitment to being able to engage in a specific plan to reach their own preferred outcomes. These are some of the general characteristics and considerations we think are important in being able to help our patients become more effective in preventing problems in the future. We have to understand our own limits. One way we think about that is that once our patients leave our clinic, they're going to do what they're going to do. And only if we have influenced their motivation at a deep and sincere level will they necessarily act in ways that will benefit their own outcomes. We have to accept, therefore, that our patients have great autonomy, and they will have the right and have the responsibility to be able to choose their own behaviors. We also have to accept that our patient plays that huge role in their own health outcomes and that we are mere facilitators in that regard. It's also useful for us to be sensitive to what maintains the risk behaviors when patients are acting in ways that aren't working for their best outcomes. And we think we work most effectively in this regard when we use effective techniques and skills to accomplish our preferred goals. We refer to what we call the cardinal rule, and that is if the health consideration in question, if what we're discussing with our patient is about their lifestyle or behavior, that is, it's a health risk behavior, then we should move to implement the particular communication strategies of behavioral change counseling. When we're talking about other issues such as collecting a history or a functional assessment of a patient, more directive questioning may be suitable. But when we're talking about something that is under the patient's control, we need to acknowledge that and engage in a mindfully deliberate change process. So we'll talk a little bit about the humbling reality, and that is that ultimately, because patients have all the power and control when it comes down to their behavior, they are the ones whose changes are most important in terms of their outcomes. So let's talk a little bit about the behavior change process. All of us, clinicians and researchers, all of us in this discussion tend to be information and data driven. We tend to seek information to inform our decisions, even though we don't always follow it exactly in our own personal lives. But we do try to make data-informed decisions. But most behavior is undertaken more intuitively, less intentionally, especially in areas where emotion and confusing motives are at play. Even though we are logical, logic doesn't always drive our behaviors. We ask ourselves, for example, why don't people change when they see that what they're doing now isn't working? When the current patterns are self-destructive, when experts advise them otherwise, even when we know we should be acting in a particular way and commit ourselves to doing so. And why also do we sometimes not even change when our current behavior is increasing or continuing our suffering? So we ask you to consider the approaches on the left-hand side and the right-hand side of this slide. When patients are suffering, as most of them are when they come to us, and we confront them with facts, with dire predictions, with admonishments, we are likely to increase their negative feelings, their shame, their anxiety, their sense of loss or rejection. So even when we think we're being helpful by aligning them to a factual approach about their current behaviors and outcomes, we can contribute to the very factors that make it difficult for them to act on their own behalf. On the other hand, when we engage in patient-centered strategies, we can increase their comfort, their acceptance of their reality so that they can move on effectively, and increase their ability to collaborate with us at the same time that they feel personally empowered. Importantly, we help them to align their behaviors with their own values and their motivations to help themselves with optimal outcomes. So why don't people change? The summary answer here is change is hard. Humans aren't always logical. In addition to that, there are some considerations for why people do change. When they think they will change, when they have confidence and feel empowered, they do. They're also more likely to if we, as their clinicians, are optimistic about their outcomes. What motivational interviewing has documented time and time again and through research is that when patients generate change talk, that is, when they hear themselves saying words that move in the direction of optimal health behaviors, then they are more likely to change those behaviors. Whereas when they engage in sustained talk, that is, talk that continues the status quo or is discouraging about their possible outcomes, that is predictive of less change. Motivational interviewing recognizes this difference and regards, therefore, the qualities of change talk and sustained talk as outcomes of the clinician's skillful or less skillful use of communication strategies to help encourage patients to change for their own behalf. Clinicians play a very important role here, therefore, and we even think about it in terms of we create the patients we treat by the way we talk to them and by the kinds of comments we elicit from them. We can engage in behaviors that increase negativity and sustain talk, or we can choose in a skillful and intentional way to engage in conversational skills that increase people's utterance of change talk that moves them more favorably toward positive directions. What we know, therefore, is that our behavior accounts for large differences in patient dropout rates, whether we retain them in treatment and long-term care, and whether they adhere to recommended protocols and reach their preferred outcomes. Empathic counseling styles facilitate change in this regard, and discord within the patient and clinician relationship is likely to impede patients' ability to change. What motivational interviewing helps us to recognize is that the mechanism for behavior change may be our skill in facilitating motivation effectively. And how we go about that with regard to motivational interviewing is caught up in this comment about the change process. What I hear myself saying, I'm likely to do. An implication of this, therefore, is that if we, as the clinician, say what it is we believe the patient should do, it is less effective than if we make comments that elicit those statements from the patients or ask questions that skillfully encourage the patient to make comments that speak about change on their own behalf. This is the process of facilitating behavioral change. We talked a while ago about trying to understand how important our behaviors are. What we as helping professionals are likely to do without intentional recognition to the contrary is to fall prey to what motivational interviewing refers to as the righting reflex. That is our tendency to step in and fix the problems we see, to generate solutions to conundrums, to answer the decision-making problems, and to tell or inform patients with regard to which side of their ambivalence we believe will lead them toward their preferred outcomes. When we are the ones who take that step, we sometimes get in the patient's way of being able to address and fix their own problems. And as indicated on this slide, the righting reflex tends to lead to power struggles and discord in our relationships, a yeah, but sort of response from patients who usually have already considered our solutions, but for whatever reasons, and we may not understand them well, have not yet engaged in those decisions. Also, when we engage in the righting reflex, it's likely to promote our belief that the patient is resistant and not being creative in terms of trying to come up with plans that would be helpful for their own betterment. So instead of the righting reflex, what we find and what research supports actually helps behavior change has to do with our figuring out how ready is our patient to make that move. An accurate assessment of where the client is on the matter of making a specific behavioral change. The counseling style that gets the patient to voice change talk is what actually helps and is shown in repeated research projects to correlate to optimal health and functional outcomes. That's we engage these processes through a reflective, supportive, communicative style that increases the patient's generation of their own change talk in confrontation or in contrast to a more directive and confrontational style that can create greater discord and escalate sustained talk. So at this point, Beth is going to take over and talk about motivational interviewing as a model and some very specific skills we hope you'll find useful in your practice.
Thank you. So I'll provide a formal definition of motivational interviewing. Motivational interviewing is a person-centered counseling style for addressing the common problem of ambivalence about change, recalling that ambivalence is that pull between the feelings of wishing that things were different and yet getting stuck along the way in that process. There are two sort of overviews to consider when thinking about motivational interviewing. The first is the spirit of motivational interviewing, a sense of how the room or how the milieu might feel when engaged in this process. This is based off of the acronym of PACE, PACE standing for the P indicating partnership. And partnership directly relates to this idea of a collaborative working relationship that the professional establishes with the patient in the room. It's not provider directed, but yet it is a collaboration between the expertise of the professional and the expertise of the patient in their life, their experiences, their culture, and their background. The A in PACE stands for acceptance, which can be broken down into different and related ideas. So considering things like the patient's absolute worth, having unconditional positive regard, being able to support their autonomy in making decisions, for instance, when they step out of your office and they have full autonomy and control with respect to the decisions that they're going to make for their health. And being able to find a place of accurate empathy, understanding and being able to demonstrate that understanding back to them about their current struggles or their current factors or variables that might impact their ability to make a change. The C in the PACE acronym stands for compassion, which is one of caring and openness towards wanting to see the best for the patient. And evocation is one of the components that really stands out as separate from traditional clinical care or traditional counseling methods that might be seen. Evocation is really about drawing out information from the patient about their experience, their ideas, their beliefs, in a way that then uses that information and that sort of starting point for motivation to be able to help someone move forward in making that change. This is opposed to providing direct education or information to the patient. That is withheld until we have enough information to be able to know that our information and our education will be helpful to them. In addition to the spirit of motivational interviewing is the fundamental processes of motivational interviewing. You can consider this your roadmap for a clinical visit or your roadmap for your time with a patient. Beginning with engagement, this is a period of more or less 20% of your time with a patient where you will really think about obtaining an array of information, checking in with the patient, kind of figuring out a little bit about what's going on. Then leading after that into focusing, which is being able to find a very one or two specific things you're going to focus on during that time with your patient, really narrowing down the broader picture into something that you can really sort of work through towards making change. The next stage after figuring out that strategic direction is evoking. This is a process where we are seeking that change talk, we're drawing it out, we are thinking about ways to emphasize it and get the patient talking about change before we take that step towards planning, which is the final process. So planning looks probably similar to what most planning might look like in a clinical visit, where we're thinking about the specifics of making that change and what the next steps will look like. There are lots of MI congruent strategies. This slide lists a good bit of them. The remainder of this talk will focus on the ones that have an asterisk next to them. These are ones that after today's talk we hope will be readily available to you to practice and try in your clinical work. Okay, so the first set of skills to talk about are the acronyms what are known as SOLAR and OARS skills. The acronym SOLAR really represents the nonverbal communication that we offer in the room when we're with a patient. So the S standing for squarely facing your patient, having an open versus a closed posture, being able to lean in to demonstrate engagement with appropriate and natural eye contact in a relaxed setting. And that these nonverbal skills really open up and demonstrate your listening, and they demonstrate an ease with helping the patient be able to continue to talk about their concerns or worries. The OARS skills represent the verbal skills that we're going to use in a session of motivational interviewing. So for example, open-ended questions are questions that really help to draw out more than just a yes-no response or a single word response, but that really open up the opportunity for a patient to explain or to work through or think about what may be some important factors for their change. Open-ended questions oftentimes will yield much more of several sentences, hopefully, of an answer, and a bit more detail so that you can kind of get a sense of where your patient might be. Affirmations are statements that are made specifically to support self-efficacy. They are comments that, or compliments that highlight someone's past successes, their abilities, their just sort of complementary qualities that support change, and that will ultimately, by drawing these out, support someone's feeling of confidence related to being able to make future changes. Reflections, or reflective listening, which make up a bulk of the verbal skills that we use, are statements that show, demonstrate understanding, that summarize or put together key information that help us move forward and change. And we'll spend the next couple of slides really focus specifically on reflective listening to give some examples of those. And summaries allow you to group together information that you've heard the patient say in order to move forward toward the next step. They allow you to kind of create a bigger picture or a more succinct picture of what the patient may be experiencing. Okay, so to focus a little bit more on reflections. Reflections tend to be sometimes one of the tougher skills to integrate, mainly because it often differs from our natural inclination as providers to ask questions. But it is also your most powerful tool that you have with respect to motivational interviewing. Reflections are statements that are made as opposed to questions that are strategic. They may restate a patient's comment. They may reference a value or something important to the patient, perhaps a reason why they may want to change, or discomfort or discouragement with the current status quo. They are not meant to drive home a point or to be a teaching tool, but rather to really underscore the patient's point of view. This not only highlights your active listening back to the client to show them your engagement and to demonstrate that empathy, but it also allows you to focus on those components that are important to the patient. They may add intensity or highlight a particular meaning to something that the patient has said. And an example of one of these may be, for instance, a double-sided reflection that may restate a contradiction between one's value and one's behavior. So, for example, that the change that they might be seeking or contemplating is important to them or is important to you as a model reflection, and at the same time you find yourself engaging in a behavior that's not congruent with the change or not congruent with health. I'd like to provide some examples of reflections with some O&P clinical examples. So imagine a patient with a lower limb prosthesis that spends most of the time in his or her wheelchair. The patient may say something along the lines of, "It takes too much time and effort to put it on. Plus, I'm just not sure I'm really ready to start walking." Now, while the reflection is listed at the bottom of the slide, I would ask you to personally reflect for a minute about what you might naturally be inclined to say in that situation. For some, their righting reflex will become strong. For others, they may really want to emphasize how important it is to wear their device and continue to provide ongoing education. But oftentimes, this can be met with, in a patient who's ambivalent, as Dr. Bob mentioned, can be met with some level of discord. A motivational interviewing congruent reflection may, instead of providing information or education, focus on an aspect that may lead us both towards the desired outcome as a practitioner and as the patient. So a reflection might be, "So if you could find a quicker way to don your prosthesis, wearing it would be easier." And the importance that I hint, and I worked really hard on that, is to be sure that my intonation at the end of that reflection went down. It's not stated as a question that I want the patient to necessarily agree with as a sort of yes-no response. It really is meant to sort of synthesize and summarize what they said in a way that hopefully focuses towards change or towards something collaborative that we could work on for the remainder of the visit. Another example may be a triathlete with a prescribed foot orthosis who is overdue for a refitting and is impatient waiting on the orthosis and continues to train despite increasing pain. They may say something as if, "I was only running a 5K, it's really not that much. I really thought I could just push through the pain." Again, you can think about what you may be inclined to think or say as a clinician, and an am I congruent reflection might say something like, "Pain was an important signal to you to come talk about how to get back to training safely." Or perhaps even, "You worried about the pain getting worse and continuing to impact your training." Reflections, again, highlight the idea that we can work collaboratively on thinking about a change that feels potentially beneficial to all. Another example, or last example of a reflection, would be a patient prescribed stretching for tightness in their calf or heel cord, chooses to play video games instead. And in my world of adolescence, I think I imagined in my mind this was an adolescent patient, but I guess it could be anyone. And they say, "I forget to do my exercises some days, plus it's uncomfortable when I do the stretches." a reflection in this particular situation may indicate it has been challenging, or may say, it has been challenging to add a new routine, and you know those stretches are important. This reflection highlights two important things by connecting both the sustained talk, which is the part that is reflected, how much it's been challenging to add a new routine, with the change talk after. By connecting those with the word "and," it really emphasizes then the discrepancy between what they want. Putting those two things together doesn't work toward moving in one direction toward health, and so being able to highlight that discrepancy means that we can also consider how to work through it. The second most important thing in that reflection is that I've also ended with the change talk component. So it could have been reversed to say, you know those stretches are important and it's been challenging to add a new routine. But in doing so, by leaving it on the sustained talk at the end of my reflection, leads likely to the patient to then comment on that part next. I neglected to say that reflections are the most powerful tool because they really leave the opportunity open for the patient to then comment next about that statement or about that reflection, something perhaps at an even deeper level than even any open-ended question could get at. So by providing this reflection and ending on the change talk, you know those stretches are important, it naturally leads the patient then to begin to talk about what makes those stretches important, therefore indicating that the patient's going to be talking more about change at that time. So that leads us into one of the next ideas, which is really thinking about how do we focus on that change talk, how do we identify it, and what do we do with it once we have it. So change talk can be broken down into two different kinds of talk. There is preparatory change talk and mobilizing change talk. Preparatory change talk really is a setup for change. It really is the early talk when people are thinking about making changes that you might hear. This includes one's desire to make a change, so how much they want to or why they might want to. It indicates their ability, how much they think they can make that change. Patient talk may suggest some of the reasons they would like to change or what they think would be better if they were able to change. And their perceived need. What's the urgency in order to make this change or to get this change done? Mobilizing change talk is a bit more intense when you hear it being said from a patient. These mobilizing change talk are things like one's commitment, so I will, I promise, I intend to make a change. They may be indication of one's activation, how the patient has wrestled through their willingness, their readiness, and their preparation, and in fact are to move forward onto the next step of change. Or it may also indicate their preparatory actions, they're taking steps toward the change itself. So getting necessary materials or supplies, setting up a proper environment, things they've started, things they've done, things they've initiated in order to make that change. So looked at it from a different perspective, what you might oftentimes hear is people starting off with preparatory talk, moving into mobilizing talk on their way toward behavior change. One of the most important things I think you can leave from this webinar knowing is that the preparatory talk is a necessary aspect toward change and oftentimes is a signal for providers of readiness. But I would caution that when one speaks of their desire or their ability or their reasons or their need, that doesn't quite indicate that they are going to make that change. They're excellent steps towards the process and ones to provide affirmations for, but they don't yet indicate that someone will make the change. We as providers can be sort of at the ready to plan as soon as we start to hear that preparatory talk. But the recommendation really would be that if that's the type of change talk that you're hearing, is to really sit with the patient in that change talk and draw it out using open-ended questions or reflecting the change that you hear to really get the client continuing to talk about change. This highlights Dr. Bob's earlier point, which is the more that patients talk about change, the more likely change is to happen. Planning for an actual change really is warranted more when you're hearing mobilizing talk, when you're hearing someone's strong commitment, their activation, excuse me, perhaps they're really, really asking for your advice at that time about what to do. That would be more of an indication of moving towards planning. So let's give some examples of how to identify and then what to do with the change talk that you hear. So a patient example would be, a quote that they would say may be, "So you know I'm a runner. Well, the new socket felt great the first day, so I figured I'd be fine to start training. I know you told me to break it in, but I've got to keep up with my training. There's no way I could take that much time to build things up." So think for a minute about this quote. While it might seem at first or on the surface highly peppered with sustained talk, there is, in fact, one area of change talk that we can hone in on and focus. And that would be this: "I know you told me to break it in," an indication that the patient was, in fact, listening, understands the guidelines and perhaps parts of the process for what they need to do in order to be successful with their socket. So while you have the option to reflect anything in that quote, the most powerful reflection that you could give in order to keep the person talking about change may be something like, "You're working hard to balance your desire to train with the long-term use of your new leg." Another example may be a parent who says, "Oh, my baby looks so hot in that helmet. I know ultimately that wearing it is temporary, but it's summer and I'm worried about him overheating. I always take it off when we're outside." So again, you can think about, there are some aspects of sustained talk in this quote, and there is at least one aspect of change talk highlighted here. "I know ultimately that wearing it is temporary." If I want to then draw out that change talk more, because I would like her to continue to wear the helmet according to its prescribed use and effectiveness, I might say something like, "You're committed to his treatment, knowing that these changes are important now and only for a little while longer." Hoping that then it continues to get the patient talking along those lines of adherence to the plan. As an example, on the flip side, if I were to reflect some aspect of sustained talk, for instance, if I were to reflect something along the lines of, "It's hard to see your baby so hot." While compassionate and demonstrates some level of active listening on my part to what the patient is saying, my expectation would then be for the parent to continue to talk about how sort of horrible or frustrating or difficult it is to see her baby maybe in a situation that wouldn't necessarily be ideal to her. It would continue her talking along the lines of sustained talk, which wouldn't help toward our overall outcome of change. So again, being able to identify that change talk is helpful and crucial to being able to keep the patient talking about change. And I believe the last example, so I'm 13 years old, and I don't see why I need to wear that back brace. My back doesn't hurt, and my friends will just make fun of me. Why do I need to do it if I'm just going to end up in surgery anyway? This one is a bit hard as I wasn't able to necessarily highlight a yellow phrase indicating change talk, but I can be cognizant of the fact that they have sort of fatalistically chosen their end of surgery when that might not be the case with the prescribed orthosis that they use. So I might reflect something along the lines of, "Wearing the brace would seem worthwhile if it could keep you out of surgery." That both continues to head us on a path of thinking about change and of wearing the brace at that time. So there are some other tools that are at your ready in order to consider how to really continue your patient talking about change. This one is what's known as the Readiness Ruler and assesses both the importance of, or the perceived importance of a change that somebody wants to make and how confident they may be. So it asks patients to consider a 10-point scale. And so on a 10-point scale, 0 to 10, how important is it for you to change a specific behavior right now? And the patient gives you a number somewhere along that number line. The same would be true for confidence. You can also ask this question, if you were to decide right now to make this particular change, how confident are you that you would succeed? And again, on a scale of 0 to 10, the patient would give you a number. to a certain degree, the number is of less importance to you than two crucial follow-up questions after each numerical assessment. So after asking someone how important that change might be to them, there are two follow-up questions. One is, well, you gave yourself a score of, and I'm just going to make up the number, so you gave yourself a score of a 6. How come you're at a 6 and not, say, something like a 2 or a 3? This question in particular, the way that it is worded, allows for the patient to think about why they have given a higher score towards importance. Why is it more important for them now? What have they learned along the way? What makes them have a desire to change, or their reasons to change, or maybe their ability because of past successes? Again, the response will be one of change talk, most likely. The second question, and again it is worded in a very particular way, is to say, so you gave yourself a score of a 6. What would have to happen for you to move to, let's say, an 8? Again, that number still the wording of that question still continues to support change, as the person really is having to focus on what it would take to get the job done, or what it would take to move to the next step. And so, not to be too confusing, but I want you to hear the difference between the wordings. If I word that last question similarly to the one before, and I'll give you the example, it will not lead to change talk. So for instance, if I said, so you gave yourself a score of a 6, how come you're at a 6 and not, let's say, at an 8 or a 9? This leads the patient to then being able to think about what might have gotten in the way, some of the barriers, the conflict, what might make it really hard. All of those statements lead the patient to talking more about sustained talk, or keeping with the status quo of behavior, instead of moving them towards change. So the wording is particular for these questions to, again, continue to evoke change talk. And then while advice giving while information or informing a patient is not always necessary in motivational interviewing, there can be a time and a place for it. It's considered rare to need to share advice or to share information, but when the opportunity does come up, there's a particular sort of path or flow with respect to motivational interviewing. Motivational interviewing would request that you ask permission before giving advice, so that you might say something to the patient such as, would it be okay with you if I were to share some ideas that might have worked with other patients? Or would it be okay with you if I also were to offer some suggestions? However, in the broad scheme of being able to give advice and asking permission before giving it, it's also really important to consider what the patient may already know. As Dr. Bob mentioned earlier, oftentimes people, when they are in the process of making changes, they oftentimes know or retain that information and education first. They may know why a change needs to happen, but still be struggling with being able to make that change. Us giving advice or information that they already know doesn't support a collaborative or partnership that I would have with my patient, and also might not be all that useful, or might just feel as though it's met with, well, I've already heard that idea and I know it doesn't work. So instead, being able to ask what they already know about a topic, or perhaps what they've already tried, may then really help you to strategize which pieces of information or advice are really important. Motivational interviewing would not support giving a whole plethora of advice or knowledge or skills. It would really support being very strategic about what one piece of information or advice that you think may help the patient make that next step. After giving that advice, it might also be very helpful to ask how they have perceived that information that you've given it, how useful they feel it might be, how that might work for them, how that might be something that would be relevant to their change. Really having them personalize that advice and taking it one step further to considering how it applies to them. Throughout the process of giving advice, one may also respect the patient's autonomy by saying things like, you might choose not to do this, and provide some ideas or some examples. Or you might think about using language that minimizes power or directives, asking their opinion about what would you think about trying it this way or considering this new change.
or being hypothetical. How might it work for you? So in wrap-up to our presentation for motivational interviewing, we have, Dr. Bob and I have, over the course of several years, gotten feedback from our students and examples from our students of clinical applicability of motivational interviewing. What might be some examples from the ONP field for when MI, especially with a patient who's ambivalent or struggling with following that recommendation, may work? And so here are some that have been suggested. The slide looks overwhelming, and I'm kind of excited about that because there's lots of different opportunities to be able to use MI in the field. And then we would hope that if there were things that you would like to do, or if you feel like MI feels like fitting work for your practice, if you'll permit us the opportunity to give 3 ideas about where next steps could potentially be for you as a practitioner, here are 3 ideas that is something you could walk out today being able to do in your next clinic. You can choose to practice your use of reflections with clinic patients and get an overall sense of response. Of note, it might take patients a little while to warm up. If they're used to very question-driven visits, it might take them a little bit of time to adjust to a new style. So offering reflections within a bit of a gentle pause afterwards is helpful for sort of reorganizing that give and take and the conversational flow of the office visit. You may consider writing your own genuine and relevant questions of darn cat that get at those use of change talk. How might you, in your particular clinic situation, get at someone's desire or their ability, their reasons, or their need for making a change? And lastly, it might be that some practitioners may choose to document one patient statement of change talk in your clinic note as a reminder for the next visit, something you can continue to draw on and use as your patient may come back over time. So the last slide that we offer is one of resources. If you'd like, these are either resources that were used in order to create this presentation, or they are resources for further reading, and we're happy to be of help for other resources that people might want for their clinical work. And here is our contact information. So at this time, I think we are open to taking questions, if there are any from the audience.
Wonderful. Thank you so much, Dr. Bob and Dr. Garland. I do have some questions from the audience that have come in. I have a question. It says, it's frustrating when I work hard with a client who then won't bother wearing the device and it never gets used to using it. How can I encourage them?
For me, I think one of my strategies tends to focus a lot on affirmations. So instead of focusing too much on their frustrations at that time just to establish rapport with them, I may also think about what they might have done in the past that has been successful, or what might be a way to be encouraging through some of their qualities that may make change a little bit easier.
I have another suggestion about that as well, and that is to have the patient reflect upon initial expectations. Perhaps to say, what were you imagining might have, how might it have changed your life to have this device? So that you get back to what were their original motivations in the first place for coming in and having a device fabricated and fit. And in that way, that may give you some change talk, some hopes and aspirations that they had experienced in the past that you can then evoke, draw out, and then reinforce with further reflections and affirmations.
Thank you. Okay, I do have a question that came in from a student that asks, does and could writing down darn cat questions make the visit seem more simulated and less real?
That's an excellent point. I think it's, to me, the way that I view it as is the first step towards sort of being able to practice these skills. So for instance, trainees that work with me will oftentimes, they might not have the exact question in front of them. That might have been something that they practiced outside of the office, but they will maybe have a little bit of a cheat sheet in front of them, or their clinic note, now that we're on electronic medical record, may have a prompt for them just of darn cat. So that along the way they're cognizant of, oh, have I heard anything about desire? Have I heard anything about ability or reason? Reasons are typically, I think, some of the easier information to gather from a patient. So I think that's a personal preference for how you feel. I wouldn't want you to sacrifice rapport in order to just be reading off of a sheet, but it might be a nice step towards feeling comfortable with those questions before you take them on independently.
In that regard, to get even more concrete about it, it can be helpful in developing phrasing to think about the particular kind of answer and phrased as change talk that you're trying to elicit, so that your question might be in the form of, what's one reason that you might want to engage in wearing this device, so that you get a desired response? Or what's one way in which you would be able to introduce this into your daily experience as a way to get at ability? Or what would be one of the functional ways that you think your life would be improved if you actually did the exercise as we had discussed in the past in order to get at needs or reasons? So thinking through the particular verbs you would use in order to elicit these particular kinds of responses can be a helpful exercise to do even before you're sitting in the room with the patient.
Thank you so much for your responses for that. I have another question coming from the audience. It says, what about the client who says, yeah, I tried that and it didn't help, or you don't know what it's like?
My first thought about that first comment is a reflection of the sort of finding the change talk within what sounds like sustained talk and trying to emphasize that. So if somebody says, yeah, I tried that, to say, you've been really diligent about putting your best efforts toward finding success. And to say that in the downward inflection, as Dr. Beth talked about, so that it's not like a question, and then leaving that thoughtful pause, the most likely response the patient is to have is to be appreciative of your reinforcement, and then to say, yeah, I really have given this a lot of thought and tried a lot of things. So instead of the discouragement about what they feel didn't work, they may feel encouraged about coming up with yet other solutions. The second part of the question has eluded me now. What was that last part, Emily?
It was, you don't know what it's like.
Yeah, and there's a great opportunity to be able to make reflections and questions that may help you get more information that can help you devise a more intentional response. So it might be possible to say, you're right, I really can't know your experience. Please help me understand better what it is that brings you in this particular position. Or please help me understand what kinds of improvements you'd like to experience. So maybe we can find ways collaboratively to come up with some solutions that would work for you and the resources available. So I might take that sort of comment as an invitation toward for getting more information and having an opportunity to express my compassion, my empathy, and my move toward partnership and collaboration.
Wonderful, thank you. So we do have a few more minutes for a couple other questions. I have one here that says, I like that I can spend time with my clients, but I am not a counselor. What if they're just too depressed or traumatized to work with me?
That's a great question. I was having a response just a while ago thinking that these kinds of responses seem to fall very trippingly off Dr. Beth's tongue and off my tongue. And we've been doing this for years and years and years. And we have opportunities to do so every day in our clinical practices. So we recognize that these are acquired skills, and they're acquired through very conscientious repetition experimentation, sometimes failure, and then also seeing the results of success. So it can feel discouraging in starting out with a new skill, but we encourage people to practice this not only in your interactions with patients, but even in your daily lives to try to introduce these sorts of skills. It's also true when you do have a patient who's experienced a lot of trauma or disappointment, sometimes there are other professional services that are helpful to them. And sometimes facilitating a referral for appropriate supportive counseling services can be beneficial. There too, you as the OP clinician have an opportunity to express your empathy and compassion and really collaborate with the patient in finding the resources that may be most important for them. I think it's realistic as well to recognize and acknowledge the limitations of our given practice and maybe being able to say, I wish I could be the person to help you with that, yet that's not within my area of expertise. What thoughts have you had about finding appropriate supports to help get you through these difficult times? So that's an example of an open-ended sort of question that will solicit problem solving from the patient rather than me trying to presume that I have the right answer for the patient's dilemma.
Mm-hmm. Yeah, as a psychologist in a children's hospital, I can't appreciate enough the sort of frontline provider that hears the initial concern, that they are empathic and lead them to me, because without that empathic response, some people won't even walk through my door. And so I really appreciate any sort of provider's empathic response to somebody's struggle in order to help them get to my door or the next best step, because sometimes people won't take that leap without an empathic or compassionate response from someone.
In the interest of discussing one of our other objectives, that notion of how to have sustained learning experiences in using these skills, I would encourage any listeners to think if you're at all inspired about the ability to use these skills to increase your efficiency and effectiveness in working with your patients. You might seek out opportunities for more extensive training in motivational interviewing. There is a website for an organization called Motivational Interviewing Network of Trainers, MINT. And at that website, there are often regional workshops that are listed for beginning individuals who are not necessarily in mental health at all, but there are people who work in a broad range of health-related and even kind of correctional professions who use these skills in order to help their patients and clients take more accountability for their own effectiveness and success. We also recognize that practicing on one's own is never as effective as getting feedback. So certainly in our training, we have had to have the experience of being observed by experts who provide us with consultation and supervision about our use of these kinds of communication skills. And those kinds of coaching experiences are available to practitioners in a broad range of fields as well. So these can be skills that can be highly honed over time, but as with practicing any new skill, it takes a lot of practice and feedback from somebody who understands the skill and the learning process to really optimize your ability to practice that effectively.
Thank you so much. We are running short on time, but I did have one more question that came in, and you may have answered part of this just now, but she asks, it seems that MI relies on multiple encounters with a patient, but often in P&O, we have few visits compared to PTs or MDs with a patient. Is it realistic to use a technique like this when time is limited and far between?
We're both nodding here. I wish you could all see that. Absolutely it is. As a matter of fact, there are several modifications of motivational interviewing that are specifically directed toward people who work in emergency care settings, for example, who may have only 5 or 10 minutes with the patient in a single contact, but still can intervene in effective ways to help patients become more aware of their own autonomy, responsibility, and capacity to do things to help themselves. So even in very brief single encounters, these skills can be used in ways that really optimize outcomes.
Wonderful. Well, thank you so much, Dr. Bob and Dr. Garland. This was a wonderful presentation, and thank you so much to those who wrote in with the questions. The recording of this webinar will be available on the Academy's Online Learning Center, and we would also like to remind those here today to take the quiz that accompanies this webinar and to join us for our next webinar, which is titled, Are You Ready for a HIPAA Audit?, which will be presented by Joyce Peroni on August 16th. Thank you so much, everyone, for joining us today.